All right, well, welcome back. So last time we finished up gait. This time, moving on to the axial skeleton. So this is going to be a combined lecture for a couple days worth of the class. So a few things before I get into the axial skeleton talk. The first is that this is going to follow the Lab 8 sheet pretty closely. So if you don't have it, you might want to either pull it up as a Word document as I'm going through this, or have a printout there in front of you, because this is going to follow pretty closely to that lab sheet. The other thing is that this PowerPoint is up in Canvas, as always. And so one of the things I would suggest is that you download the slideshow rather than just opening it in a window in Canvas, because the way I've set it up, and a bunch of my PowerPoints are like this, but it's especially helpful with this one, is if you download it, then when you run through it, so you'll see this is the ethmoid bone, but you'll see I've layered the pictures on top of each other, and so you can get a bunch of different views if you download the slideshow. So otherwise, you're just stuck with this view. So I would recommend download the slideshow and actually run through each of the pictures, and that'll make things easier for you to help you find stuff. But rather than just go through the slideshow, I thought it would actually be a little bit more helpful if, instead of doing that, at least for this first part when we're talking about the bones of the skull, if I actually showed you how to find them on the anatomy app. So what I've done here, there are different models, as you probably know, on the anatomy app. So I'm using, at the moment, just the head and neck model. So I'm going to go through that order on the Lab 8 sheet and show you how to find each of those things, each of those bones on this. I've isolated just the skull, so I'm going to show you how to find them on the skull. But like I said, if you don't want to use the anatomy app, or if this doesn't quite make sense to you, you can just fall back and use the slideshow that's posted in Canvas. All right, so first things first is the ethmoid bone. And so the ethmoid bone, probably the easiest way to find it, to make sure I click on the right bone, is on the medial aspect of the orbit of the eye. So obviously the orbit of the eye is this bony ring right here, and your eyeball sits in there. And so the ethmoid bone is there on that medial aspect of the orbit. But in addition to helping form the medial aspect of the orbit of the eye, if I tilt him back a little bit, you can also look up in his nose. And so there comes the green highlighting again. So you'll notice when we look up inside of the nose that you can see the ethmoid bone in there as well. And that's because the ethmoid bone helps form the roof of the nasal cavity. And in fact, that aspect of the bone has a bunch of tiny holes in it that allow the filaments of the olfactory nerves to pass through that bone and into the nasal cavity. And so the olfactory nerves, remember, olfaction is smell. And so those nerves relay smell signals from that nasal cavity back to the brain. So we have to allow those nerves to pass through the skull in order to reach the nasal cavity. And so the particular bone that they pass through is the ethmoid bone. In addition to that, I'm actually going to isolate this bone so you can see it there. So we're just looking at that straight-on anterior view of the bone. And so you can see how it forms the roof of the nasal cavity. And so this midline here is the nasal septum. And so the nasal septum divides the nasal cavity into left and right halves. And so the ethmoid bone plays a role in dividing the nasal cavity into left and right halves. And then the other things you can see on here, these little ridges, here's one, here's another, those are called the nasal concha. And so what those do is they help create turbulence in the air that we breathe in. They help kind of spin the air around as we breathe it in. And so that does a couple things. It plays a role in filtration of the air, because obviously you've got mucus in there, you've got some hairs in there, and so that turbulence in the air helps filter it, helps us pull out, or helps us, particularly in the mucus inside of the nasal cavity, helps us capture things like bacteria and dust and those kinds of things that we don't want getting down into the lungs. And then it also helps us to warm the air that we breathe in. So especially as the weather gets colder, if you're outside exercising, it becomes more important to be able to warm that air up before it goes down into the lungs. And so those concha increase the surface area inside of the nasal cavity and play a role in not only creating that turbulence, but also then there's a bunch of little capillaries superficial to those concha that help warm the air that we breathe in. So that's the ethmoid bone. And then we'll put the skull back together. So that's the first one. Then from the ethmoid bone, we're going to move on to a really obvious, easy one, and that's our frontal bone. And so you can see the frontal bone there. A couple things about it. First is that it makes up most of your forehead, and then the other thing that would be worth knowing is that it makes up the superior wall of the orbits of the eye. And so you can see that superior wall there. The frontal bone, if we spin the skull and look at it from the right side, so then you can see everything in front of this suture is the frontal bone. So this whole green thing, that's your frontal bone. And so remember, thinking back to the lobes of the cerebral cortex, the frontal lobe sits just behind, so just posterior and, in this case, inferior to that frontal bone. So the frontal bone overlies the frontal lobe of the cerebral cortex. So that's that one. And then on to the occipital bone. So to find the occipital bone, we got to spin the skull around and look at the posterior aspect. So the occipital bone is all of that. So the occipital bone makes up most of the posterior aspect of the skull, but also, if we look underneath, makes up most of the base of the skull. And there's a couple important features in or on the occipital bone. I'm going to keep pulling them up a little bit. There we go. So there are these condyles here. So this this kind of grayish area here, that's an articular surface. So you got one condyle on the right, one condyle on the left, and that's where the occipital bone articulates with the most superior bone of the vertebral column or of the spine. And so that bone is called the atlas. And so the superior articular facets of the atlas articulate with these condyles here on the occipital bone. Another important feature is this giant hole here, which is the last thing on that front page of the Lab 8 sheet. That's called the foramen magnum. So foramen magnum is big hole, is what that means. And so that is the large hole at the base of the skull that allows the spinal cord to interact with the brain. So the foramen magnum then is part of the occipital bone. Another interesting thing that you may have noticed on your own occipital bone, so there's a fairly obvious knob here on most people. So most people have kind of a pretty obvious bump near the base of their skull. That's called the external occipital protuberance, is what that bump is. And so sometimes, you know, if you're getting a haircut, especially if you're a guy, then sometimes they may actually accidentally bump that with like the clippers. Other things though, so you can see these flat areas here, so your traps and some of the neck musculature insert there on the occipital bone, and so they help rotate and also extend the neck and help you look up. So then the next one, I'm going to zoom out a little bit, is our parietal bone. So we're going to go from the occipital bone that we're on now to the parietal bone. And so there are two parietal bones, there's a right and a left, so we're going to look at the right side. So there's your right parietal bone, and so you can see that makes up most of the superior and lateral aspects of the skull. And you know, thinking again back to the lobes of the cerebral cortex, so obviously your occipital lobe is in the back, so near the occipital bone, and then the parietal lobe of the brain is on top, right? And so here's your parietal bone. So again, there's the right parietal bone. If I look at it from the posterior aspect, here's your left parietal bone. So the right and left come together. So those are your parietal bones. Those are pretty straightforward. And then the sphenoid. So the sphenoid, we're going from straightforward bones to a very complicated bone. So the sphenoid bone, the easiest place to find it is right here. So you can see it on that external wall of the skull there, on that lateral aspect. So it is kind of between the parietal, frontal, and temporal bones, so it sits in there. But if we rotate the skull and I show you inside of his eye orbit, you can see that it makes up most of the posterior wall of the orbit of the eye. And in addition to that, it has several holes in it, and so you can see a really obvious hole here. That's going to allow for the passage of the optic nerves from the eyeballs back to the brain. So that's an important hole. There are other holes in the bone, so I'm going to isolate this one just like I did with the ethmoid. So if we isolate it like this, so it's supposed to look kind of like a bat, and it kind of does, I guess. You know, like a bat that lives in a cave and flies at night. So it's supposed to kind of look like that. And so you can see there the hole for the optic nerves, but there are other holes. If I look at it from the posterior and superior aspect, you can see a couple of other holes there. And so the other holes in the bone are going to allow for nerves that innervate the muscles of the eye, but also some of them allow for the passage of nerves that innervate the muscles of the face that allow us to make expressions, but also that allow us facial sensation. So there's some important little passages in the sphenoid bone. One of the things about the sphenoid bone is that it's oftentimes called the keystone bone of the cranium. So not of your face, but of the cranium, which is the part of the skull that your brain sits in. And the reason it's called the keystone bone of the cranium is because it articulates with all of the other cranial bones. So if we go back and put all the other bones on there, so you can see it's going to articulate with the frontal bone, with the parietal bone, with the temporal bone, with the occipital bone. If I look up underneath, it articulates with the occipital bone through here. So that's why it's called a keystone bone of the cranium, because it articulates with all of the others. So that's your sphenoid bone. And you can see it also makes up way back the most posterior aspect of that nasal cavity as well. So sphenoid bone, one of the ones I'm sure you've never heard of, does quite a few things. All right, so then speaking of bones that do quite a few things, we're going to go to the temporal bone. So from the sphenoid bone that's currently highlighted to the temporal bone, there we go. So one of the interesting things about this one, so the name for the bone comes from the Latin word temporum, which means time. And so the reason for that naming is because typically when you get gray hairs, they're usually on the side of your head first. Not always, but speaking from experience, they started on the sides of my head. And so that's why it's called the temporal bone, because it indicates the passage of time. In your temporal lobe of the cerebral cortex obviously sits inside of that, right? So that's another one of the aspects of the cerebral cortex that corresponds to a bone that overlies it. So there's some important features on the temporal bone. The first is the zygomatic process, which is here. And so that's going to articulate with or interact with the zygomatic bone, which is here. We'll come back to it later. But so you've got the zygomatic process here that helps make up kind of that posterior aspect of your cheek. Forms a pretty obvious bony ridge right in front of your ear, or just anterior to your ear. In addition to that, so I'm actually going to pull off his lower jaw for a second. And we're going to see if I can bring it back. So you've got this really obvious indentation right there. So that's called the mandibular fossa. And so the mandibular fossa allows the interaction of the mandible. So I'm going to go back and highlight the temporal bone again. So that allows the interaction of the mandible, which is that lower jaw. And so that helps form the temporomandibular joint, or TMJ. So oftentimes people will have problems there. So sometimes people will have like tension headaches that can be related to dysfunction at the TMJ, temporomandibular joint. So anyway, that's the interaction of your lower jaw with the skull, is there at that mandibular fossa on the temporal bone. In addition to that, it also has a couple or a few important holes in it. So it has a canal that allows your internal carotid arteries to pass through, which supplies 80% of the cerebral hemispheres with blood. So that's a pretty important little passage there. This hole here is called the external auditory meatus, and so that is going to allow for the passage of sound into the skull, and so that actually technically allows the passage of sound into the middle and inner ear cavities, which are inside of the temporal bone. So it houses those middle and inner ear cavities. And then two other important features on the temporal bone. The first is right here. This is called the mastoid process, and then the other one is right here, and that's called the styloid process. And so between those two processes, you've got important sites for insertions of neck muscles. So for example, one of my favorite muscles that you don't have to know, but it's one of your really obvious prominent neck muscles, is called the sternocleidomastoid, or SCM for short. And so the sternocleidomastoid tells you where it runs, has an origin on the sternum, has an origin on the clavicle. Those two origins run together and they insert on the mastoid, hence sternocleidomastoid process of the temporal bone. And so both of those, or you have a right and a left, those muscles are really important rotators of the neck. So anyway, that's the mastoid process. So both the mastoid and the styloid are important sites for muscle insertion, specifically of insertion of neck musculature. Next, we can stay with this view. We're going to go to the lacrimal bone, which is right there. There we go. So the lacrimal bone, The way that I remember where that is, so your tear ducts are called your lacrimal ducts, so they sit pretty close to this bone. And so the lacrimal bone is about where your tear ducts are. So things about it, so it obviously contributes to the medial wall of each orbit, but it also has a groove right here on its anterior aspect that's going to contribute to this hole. So you can see this little hole right here. That's called the lacrimal fossa. And so that hole drains directly down into your nasal cavity. And so that's why whenever you cry or tear up, your nose starts to run, because that fluid, rather than running down your cheek, actually runs down into the nasal cavity, and so then that causes you to have a runny nose whenever you're crying or whenever your eyes tear up. So it's because of that lacrimal fossa there. So anyway, that's your lacrimal bone. Then we'll stick with this view. Got a really obvious one here. So that's your mandible. So your mandible is your lower jaw. Things about it. So it has a body, which is the majority of it. So all of this is the body of the mandible. And then it has two rami, singular is ramus. So we're looking at the right ramus here. And so that's the vertical projection from the body. So this is the right ramus of the mandible. And then it has two processes. So there's an anterior process here, and then a posterior process back here. The anterior process, this one, is important because that's a site of insertion of a muscle called the temporalis muscle. And the temporalis muscle, you can see this line right here on the lateral aspect of the skull. The temporalis muscle takes up most of this space on the lateral aspect of the skull and then inserts there on that anterior process of the mandible. The temporalis muscle is a really important mastication or chewing muscle. So it's one that closes your jaw, but it also retracts your jaw, so it pulls your jaw straight backwards. And so it plays an important role in chewing or just biting down. So on the posterior process, we've kind of already talked about it, right? So it's going to articulate with that fossa on the temporal bone to form the temporomandibular joint. So that's the bone-to-bone connection between the mandible and then the rest of the skull. All right, so then the next bone is the maxilla. So we can see the maxilla here, but I'm actually going to spin him around a little bit, and we'll look at him from the anterior aspect, or kind of a three-quarter view. So the maxilla is your upper jaw. So your upper teeth originate in the maxilla, but you also, as you can tell here, have a right maxilla and then a left maxilla over here, and those two are fused at this midline. I'm going to click back to the right maxilla. There we go. So other things to know about it, in addition to your top teeth originate there, it also forms part of the bottom orbit of the eye. So you can see its role in forming the eye orbit there. And then if we can look at the underside of his skull, which is going to take a little bit of doing, rotate him this way. There we go. You can also see that the maxilla makes up most of the roof of your mouth. So it makes up most of what's called the hard palate. And so the hard palate is that bony roof of your mouth. In all of us who are living, we also have a soft palate, which is some soft tissue back here. And the soft palate's job is to separate the nasal cavity from the oral cavity. So to separate the back part of your nose from your mouth. And so the soft palate, what it does when we swallow, it kind of flaps shut against the nasal cavity, and so it keeps food from moving up into the nasal cavity. If you've ever, had a drink of milk or something and then laughed while you were in the process of swallowing and like milk came out of your nose or something like that, basically what happened was that force of you laughing propelled whatever that fluid was up into your nasal cavity before that soft palate had a chance to shut. So we would all have a soft palate, but obviously since we're just looking at a skull, since we're just looking at bony tissue, there isn't a soft palate here. So as it pertains to the maxilla makes up most of the hard palate. So you can see the right maxilla there, left maxilla there, and so again, they form most of that bony roof of the mouth. Then we're going to go back to an anterior view to zoom out a little bit and rotate him. All right. Come down some. So that's the left maxilla. So the next bone is the nasal bone, which is right there. So just like with the maxilla, there's a right and a left. So I'm going to click back over to the right because I try to stay on the right side as much as I can. All right. So things to know about the nasal bone. So obviously it's roughly rectangular, and you can see that there. The only other really relevant thing about the nasal bone is that the cartilages that form most of the skeleton, if you will, of the external nose. So you've got that hyaline cartilage there that forms most of your actual nose. Those cartilages attach there at the nasal bone. So that's the one interesting thing, I guess, about the nasal bone. Then on to the palatine bone. So the palatine bone, I don't know if it's palatine. Anyway, that's the easiest way to find that is in the roof of your mouth. So it's just behind the maxilla that we were looking at a second ago. Ignore that. That's the occipital bone. All right, so the palatine bone, or palatine, however you want to pronounce it, is right there. So again, there's a right and a left. So we're looking at the right palatine bone. So again, that's going to make up the posterior aspect of the hard palate on both the right side and the left side. So technically, the palatine bone has a horizontal component and a vertical component. So it's the horizontal component that makes up the roof of your mouth, and then the vertical component, if I rotate him this way a little bit, you can see the vertical component in there. So there's the vertical component of the palatine bone. And so that's going to play a role in helping to form the posterolateral walls of the nasal cavity, so the back side aspects of the walls of the nasal cavity. And then last is our vomer. So the vomer is inside of the nose. I'm going to rotate him a little bit. So there's his vomer. So the vomer, I'm going to look in his nose. There you go. Rotate him some more there. So you can see that the vomer articulates with the ethmoid, which is the first bone that we talked about. So I'm going to click on the ethmoid. So there's the ethmoid again. Remember, that's where we started. So just inferior to the ethmoid is the vomer. There we go. And so those two help form that nasal septum that again divides the nasal cavity into right and left halves. And I'm going to show you if we can look at the underside of his skull here. So you can see the vomer in there, and then the ethmoid is right there. So the thing to know about the vomer divides the nasal cavity into left and right halves. Oh, that wasn't the last bone. One more. Yeah, one more. So then we got the maxilla, which is here. So the maxilla is more colloquially known as your cheekbone. So you can see the right maxilla, sorry, I said maxilla twice. The right zygomatic bone there does interact with the maxilla, which is up there. But anyway, so there's your zygomatic bone right there. And again, that's going to interact with that zygomatic process on the temporal bone. And so again, the zygomatic bone is known as your cheekbone. And in addition to that, in addition to being your cheekbone, it also forms part of the orbit of the eye through here. So you can see it forms those, or that inferolateral aspect of the eye orbit. So sometimes when people get facial fractures, they'll get them potentially in the zygomatic bone, potentially at this suture here between the zygomatic and temporal bone, and then less likely they may get a fracture back here on that zygomatic process of the temporal bone. All right, so there's your zygomatic bone. And again, as you expect, you have a right and a left. So that's the right side. There's the left side on the zygomatic bone. And then the last thing on your lab sheet, we already talked about with the occipital bone, but if we look at the skull from underneath, is your foramen magnum. So again, there's my occipital bone. Whoops, pull this skull up a little bit so it's in view. Then we'll zoom in. It's okay, we didn't really need the highlighting. But anyway, so this big hole here in the base of the skull, that is your foramen magnum. All right, so that should be the first page of the Lab 8 sheet. So those are all the bones of the skull that I want you to be familiar with. And then I'm actually going to switch back to the whole body skeleton because I'm going to talk about the spine. All right, so pull him up a little bit, rotate him, so we'll look at his low back. Okay, and at this point I'm going to switch back over to my slideshow. And I'm going to click ahead through the bones of the skull and into the vertebral column. All right, So as you can see, the vertebral column is also known as your spine. So there are 3 sections primarily to the vertebral column. So the first is the cervical section. And so the cervical section is better known as your neck. So the cervical section is your neck. And then this number in parentheses is the number of bones or vertebrae in each section. So the cervical section has 7 bones, 7 vertebrae in that section. So, and I'm going to skip ahead to where it says numbering here. Let me see if I can bring up a full screen. I don't know why I can't get rid of that. That's okay. Anyway, so you'll see down here numbering. For example, the atlas, which is the most superior vertebrae, is C1. And so the way that we talk about vertebrae is we first describe which section of the vertebral column that vertebrae sits in, and then we start at the top is number 1 in that section, and then down to the bottom is number 7, 12, or 5. And so the top vertebrae, or most superior vertebrae, is C1, and then the one below that is C2, because again, it's in the cervical section. First vertebrae, cervical section, second vertebrae, on down to the last bone in that section is C7, so the 7th cervical vertebrae. Then the thoracic section is next, and so the thoracic section is the middle of the spinal column, or of the vertebral column. And so starts with T1 on down to T12. There are 12 vertebrae in that section. And then each of those vertebrae interacts with a rib. So the thing to know about the cervical section, that's your neck. The thing to know about the thoracic section is that each of those vertebrae interacts with a rib. So it helps form the posterior aspect of your thorax. And then the lumbar section, there's 5 vertebrae there. So starting with L1 on down to L5. So the lumbar section, these 5 vertebrae make up your low back. So lumbar section, low back. And then you don't need to know these. I kind of threw these in here as fun facts. So you've got the sacrum, which is here. And so the sacrum sits between each of those innominate bones, thinking back to when we talked about the pelvis. You have a right innominate bone, a left innominate bone, and then between them on the posterior aspect is the sacrum. And so the sacrum is actually formed from 5 fused vertebrae. It is effectively one bone, but it's formed by the fusion of 5 vertebrae together. And so that's why I have a 5 there. And then your coccyx, down here is your tailbone. And so the number of bones in people's tailbones varies a little bit. So it's between 3 and 5 for most people. So 4 is a good average number, and that's actually what the textbook for the class lists is 4 bones in that section. Doesn't really matter. But anyway, so there's some variability in your tailbone in terms of the number of bones. In terms of the spinal curves, so there's 2 types of curves. There's a lordotic curve and kyphotic. I know kyphotic fell off the screen there. Kyphotic is spelled Kyphotic, kyphotic. And so a lordotic curve, there's 2 lordotic curves in the spine. The first is in the cervical section. The second is in the lumbar section. A lordotic curve is convex, so curves out anteriorly. So lordotic curves are convex anteriorly. And then kyphotic curves are the other way. So the kyphotic curves, there are 2 of them effectively in the vertebral column. So the first one is in the thoracic section. That's a kyphotic curve. And then the second one, if you count the sacrum and coccyx, is down here. So the second kyphotic curve is the sacrum, or formed by the sacrum and the coccyx. So a kyphotic curve then is concave, caves in on itself anteriorly. So lordotic curve, convex anteriorly, found in the thoracic and lumbar sections. Kyphotic curve, concave anteriorly, and then found in the thoracic and sacral sections of the vertebral column. All right, so motions of the spine. So we've got flexion extension, and so this guy here bending forward is in flexion of the spine. So when you bend forward, that's spinal flexion. And then in the neck, when you look down, that's spinal flexion. Spinal extensions going the other way, so that's either standing straight up, so this guy is actually hyperextending his spine a little bit. So spine extension is standing straight up or leaning back, and in the case of the cervical section, extension is looking up. So that's cervical extension. And then we have lateral flexion, right and left, which is leaning right and left. So sometimes it's called side bending, which you can see that kind of down here. And so I'm going to refer to it as lateral flexion. So the more obvious picture here, this is lateral flexion to the left. So that's effectively leaning left. And then lateral flexion to the right is over here. So he's leaning to his right. And then rotation, if you rotate to the right, in the case of the thoracic section or thoracic and lumbar sections, if you rotate to the right, that means to take your sternum, rotate it toward your right. Left rotation, take your sternum, rotate it toward the left. And then the cervical section, our reference point is the chin instead of the sternum. And so you can either look to your right, which is right rotation in the cervical section, or you can look to your left, which is left rotation in the cervical section. So those are the motions of our vertebral column. All right, so let's talk about vertebrae. So, and I'm going to try to see if I can see the bottom of the slideshow here. Maybe not. I'm going to retry this. Nope. What about if I minimize it and come back? See if that works. I'm going to come back to that guy. And then maybe, and if not, then I'll give up on it. Hey, there we go. All right. So, in terms of features common to all vertebrae. So remember, a vertebrae is a bone of the spine. So they do have more in common than they have different. So what you're looking at here is a lumbar vertebrae, so a low back vertebrae from the top. So it's a superior view of a lumbar vertebrae. So in terms of the features that they all have in common, the first is that they have a body. And so in terms of orienting yourself, so down here, this is the anterior aspect of the vertebrae, so it's closer to your front. And then this is the posterior aspect of the vertebrae, so it's closer to your back. So the body of the vertebrae is all of this. So that's the body. And your intervertebral discs sit on top of that body. So that's why you've got so much space there. One of the things that separates lumbar or low back vertebrae from the other two sections is they have the largest bodies because they have to bear the most weight. So the lumbar vertebrae have really big bodies. Then from the body, we can go posteriorly. So this projection here is called the pedicle. So it kind of looks like a pedestal, right? It sounds similar. And so this is the right pedicle. I know it's on the left side of your screen, but in a person it would be on their right side. So this is the right pedicle. This is the left pedicle. And then the lamina runs from the pedicle to the midline. So all of this is the right lamina, and then all of this is the left lamina. And so what those two do is the pedicle creates some space here, and then the lamina sort of forms the roof of something called the neural arch or the vertebral arch. You'll see both terms. And so that forms that neural or vertebral arch, and so your spinal cord sits in here. And so this hole is the last term down here. That's the vertebral foramen. So remember, a foramen is a hole. And so this hole, the vertebral foramen, your actual spinal cord sits there. Remember, your spinal cord is a bundle of nerves that relays sensory information back up to the brain and then motor information away from the brain. So the idea, or one of the things that your spine does, is it helps protect that tissue. So it helps provide that bony ring around it so that you're less likely to damage your spinal cord. So that bony ring then is formed by the combination of the right pedicle, right lamina, left lamina, left pedicle, and then anteriorly the body of the vertebrae. Then we've got several processes. So the first is the spinous process. So the spinous process is back here. And so it is this posterior projection off of the vertebrae. So the spinous processes throughout the vertebral column are palpable, meaning you can touch them. So if you've ever kind of felt along your spine, you'll notice a bunch of little bumps. Those are the spinous processes of each of the vertebrae that you're feeling there. Then we have transverse processes, and so here's the right one. So there's a right transverse process, and then there's a left transverse process over here. And then we have the articular processes and facets. So now I've switched views. Now you're looking at the same vertebrae. So it's still, I think this one's L3. You're still looking at the same lumbar vertebrae, but now you're looking from the right side. And so in terms of orienting yourself, so here's the transverse process here. Here's the spinous process back here. And then the superior articular process is all of this. And then the facet or facet is the articular surface. And so you can see here this kind of gray area that's supposed to indicate articular cartilage. So that's going to interact with the superior articular facet from the vertebrae below. So we've got superior articular process, and you can't see the facet because we're looking at it from a lateral angle. But now, so the bottom picture here, this is a posterior view. So here is the superior articular facet on the right side, superior articular facet there on the left side, and then this is the process, so the non-articular part of it. So superior articular process facet, inferior articular process, and then inferior articular facet here. So why are those things there? Those are there to allow for motion in the spine. So I'm going to zoom in on him a little bit, and I'm going to look at two vertebrae. So I'm going to pick two of the lumbar vertebrae. There's L2. We're going to do a multi-selection. I'm going to pick L3, and then we're going to isolate those two. All right, so now you're looking at the anterior view of them, and we're going to flip it around to a posterior view. So you can see here the inferior articular process of L2 interacts with the superior articular process of L3. And so then what ends up happening is as you flex the spine, so as you bend forward, this superior articular process is going to slide up. So it's going to slide partially off of, this inferior articular process, I should have said, it's going to slide up off of this superior articular process of L3. And then if we extend the spine, then they overlap more. So L2 is going to rotate backwards, and its inferior articular process is going to overlap more with the superior articular process of L3. And I've got a good picture of that I'll show you a little bit later in the slideshow. But anyway, so those are referred to as the facet joints. So the interaction between an inferior and superior articular processes and facets of adjacent vertebrae. All right. So those are the things that the vertebrae have in common. Now let's get to some differences between the sections of the column. So in the cervical section, so in the neck, there is one particular unique feature that's not found in either the thoracic or the lumbar section. So the vertebrae you're looking at here is C6, so it's close to the bottom of the neck. There's only one more below it, which is C7. But the unique feature is what you'll notice here, which is the transverse foramen. So anything transverse is off to the side, a foramen is a hole. And so in the case of the cervical section, each of the vertebrae has a transverse foramen, which is a hole on either side of the body. Why is that there? You've got vertebral arteries that help supply the brain, and those vertebral arteries sit there in that transverse foramen. There's a side view of C6 or a lateral view of C6. All right, so let's go to the thoracic section, so the section that interacts with your ribs. So there are some unique features in the thoracic section, and those are associated with the ribs. So what you got here is a superior view of T5, so the fifth thoracic vertebrae, and then I'm going to switch to a lateral view. And so the unique features in the thoracic section are costal facets. So anything that is costal deals with the ribs. So a costal facet is some sort of an articular surface, in this case for a rib. So there is a superior costal facet, which is this articular surface here. That's the superior costal facet. And then there's an inferior costal facet there. And then a transverse costal facet here. So the way it's going to work is that there's going to be a rib that'll sit between this vertebrae and the one below it. And so the facets on the rib interact with the inferior costal facet of, in this case, T5, and then the superior costal facet of T6. So if we add a rib in here, this is actually T4, T5. But you can see the rib interacting with this inferior costal facet there, and then the superior costal facet down here. And then there's a tubercle on the rib, and there's a facet there, and so then that's going to interact with this transverse costal facet down here on T5, but it's covered up, of course, by the rib. So that's why that transverse costal facet is there. All right, so speaking of unique, there are a couple of unique vertebrae that are quite unlike the others, and those are the most superior two vertebrae in the cervical section. So the most superior of all vertebrae is C1. Its other name is the atlas. So the name comes from Greek mythology. I don't know how familiar you are with that, but before the Greek gods, before Zeus and Athena and, man, I should know my Greek gods better than this. Dionysus, trying to make sure I don't list some Roman gods in there. But anyway, before Zeus and all of the rest of them, Hera, before that group, there was a group called the Titans. And so the Greek gods, Zeus et al., defeated the Titans, and then they subjected them to different punishments. And so one of the Titans' punishment was to hold up the world. And that Titan's name was Atlas. And so in terms of the vertebral column, your atlas holds up your world, aka your skull and brain. And so your top vertebrae that holds up your skull is called the atlas. And so that's the C1 vertebrae. And so what you've got here is a superior view of C1, and you can see its unique superior articular facets here that are going to interact with those occipital condyles. So the condyles on the occipital bone that I showed you earlier, these superior or specialized superior articular facets on the atlas will interact with those. And an important thing to know about that interaction, so the name of that joint is called the atlanto-occipital joint, because it's the interaction between the atlas and the occipital bone, so atlanto-occipital joint. So the important thing to know about that is you get quite a bit of anterior and posterior rotation, so viewed as basically flexion extension. So there's lots and lots of flexion extension at that atlanto-occipital joint. So most of our range of motion when we say yes, so that forward and backward rotation, comes at that atlanto-occipital joint. We get a little bit more rotation or a little bit more flexion and extension in the rest of the cervical section, but the vast majority of that range of motion comes there at that atlanto-occipital joint. So the interaction between C1 and the occiput or occipital bone. Then we've got C2, if it'll let me click to the next bone. There we go. So there's C2. So you'll see C2 also looks a little bit different than the rest of the vertebrae. It has this really obvious projection here, and that's called the dens. And so the dens projects up into the anterior arch, which is this thing, on the atlas. So if I put those two together, so there's a superior view of the two together, so you can see that anterior arch of the atlas, you can see the dens there, and then in us, there's a transverse ligament that closes in that space, that keeps the dens inside of that arch. So the interaction of those two, so there's an anterior view of the interaction between, this is the atlas, this is the axis, here's kind of a posterior three-quarter view. So again, here is your atlas, and then down here is your axis. And you can see the dens there. And so that particular joint is called the atlanto-axial joint. Again, the interaction of the atlas and the axis, so the atlanto-axial joint. And important to know about that is that you get a lot of left and right rotation at that joint. So most of our range of motion when we say no, so when you rotate left and rotate right, comes at that atlanto-axial joint. So basically we say yes at the interaction between the atlas and the occipital bone, and then we say no at the interaction between the atlas and the axis. Like I said, you do get a little bit of additional range of motion throughout the rest of the cervical section, but the vast majority of it comes at those joints. All right, so this part isn't on your lab sheet, but it's just a quick, I feel like I would do you a disservice if I didn't mention these. So the intervertebral discs. So here's one. So the intervertebral discs are discs, rings of fibrocartilage that sit between the bodies of the vertebrae. So thinking back to Chapter 8 when we talked about joints. So these are a type of cartilaginous joint specifically. They are symphyses because they are two bones joined by fibrocartilage. And so the discs have two components to them. The most superficial component is called the annulus fibrosus. And so that is that outer layer of fibrocartilage. And if we explode those two, so Here's one lumbar vertebrae. I forget which two I put on there. I think it's L3, L4, but it doesn't matter. Anyway, here's one lumbar vertebrae. Here's another one. Here's the disc that sits between them. So this outer portion of the disc is the annulus fibrosus. And so you can kind of see it, but not super well. But it kind of looks like rings on a tree. And so there are different layers to the annulus. And so inside of each layer, the collagen fibers run a different direction. So they all run obliquely. So they all run, low on the left to high on the right in one layer. And then on the layer deep to that, they'll run the other direction. So they'll run high on the left to low on the right. So they form sort of a series of X's, or a series of overlapping oblique fibers that help make up that annulus. And why that matters, that helps make the annulus resistant to a variety of stresses, whether that is rotational stress or compressive stress. So again, those are the collagen fibers that make up the annulus. Because again, thinking back to when we talked about joints in Chapter 8, most of fibrocartilage is collagen fibers. It doesn't have quite as much water content as hyaline cartilage does. And then the inner portion of the disc, so this darker gray here, is called the nucleus pulposus. And so the nucleus pulposus is kind of like a jelly material. It's mostly water. And so that is something, the hydration status of that changes throughout the day. So one of the things, if you want to measure your height, for the football program or the basketball program or whatever, and you want to be as tall as possible, measure your height first thing in the morning. Because when you are non-weight bearing all night, so when you're laying down, that takes that compressive stress off of the discs, allows them to rehydrate, and so your discs will fill up with water, or at least that nucleus will fill up with water, and so that'll make you a little bit taller. And then by the end of the day, after you've been sitting and standing all day, that compression pushes out some of the water content, and so you're actually a little bit shorter at the end of the day than you are at the beginning of the day, and then we start that whole process over again. And we see that too as we age, so the discs get less able to rehydrate themselves across the lifespan, and so that's one of the things that contributes to shrinking in elderly populations, is that decreased hydration of the discs. And so for what it's worth, if we go back to the side view, you also have this intervertebral foramen here. So you've got nerve roots that come out here, and so if we get a shrinking of the discs, well, that closes down this space and makes it more likely that you're going to press down on a nerve root. And when you press down on nerve roots, you're going to get sensory deficits. They can't feel things, or they get tingling, and then motor deficits. They're not quite as strong. And so that's one of the reasons, or one of the things that contributes to back pain and neck pain, etc., in older populations, is actually that lack of hydration, that lack of disc height, then closes down on this space and then impinges on nerves. So I mentioned earlier that I had a picture of this. So we talked about the facet joints. So when this guy is bending forward and he's in flexion, so what that's going to do is it's going to compress that anterior aspect of the disc, pushes the nuclear material posteriorly, but then it also opens up the space. So there's not, there's no actual gap between, but basically the superior articular facet slides partially off of, but not completely off of, the inferior articular facet down here. And then it's going to open up that space. And then similarly, when we extend the back, you can see you close down that space, but also you get increased overlap between the facet joints. And so that's how the interaction between those structures works. All right, so I have a few ligaments for you to be aware of in the vertebral column, and I think I might have not put this on the lab sheet. So if I didn't, I apologize. Write it on the back of page 3. But the ligaments to be familiar with, the first one are the intertransverse ligaments. So what you're looking at here is a posterior view of the lumbar section of the spine, so a posterior view of the low back. And so remember that, so here's one lumbar vertebrae. So this is, let's see, what do we got here? So L5, L4, L3. All right, so here's our L3. So remember that it has transverse processes. So here's its right transverse process, here's its left transverse process, and then L2 up here. So here's its left and right transverse process. So the intertransverse ligaments, inter is between, so the intertransverse ligaments run between the transverse processes of adjacent vertebrae. What do they limit? They limit lateral flexion or side bending. So as I bend to my right, or as this person bends to his right, we're going to get compression on this side, which is going to put slack in these ligaments, but it's going to put tension on this side. It's going to pull these ligaments apart a little bit, and so they are going to limit that range of motion. So the intertransverse ligaments then limit lateral flexion of the spine. Then I'm going to cheat, and I'm going to use a netter picture. So this is up in Canvas. It's among the netter diagrams. So what you got here is a as you can see from the slide, a left lateral view of the spine. And so he's actually cut through the bodies of the vertebrae here. But in terms of those ligaments on that left lateral view, so the interspinous ligaments sit between the spines of adjacent vertebrae. So those are going to limit flexion of the spine. So as you bend forward, it's going to stretch out these interspinous ligaments, so they're going to limit that. And then we have an anterior longitudinal ligament that runs on the front side or on the anterior aspect of the bodies of the vertebrae, and you can see it labeled over here. That's our anterior longitudinal ligament. So it is going to limit extension of the spine. It's also a really important stabilizer of the spine because it attaches to both the bodies of the vertebrae and the intervertebral discs. So the anterior longitudinal ligament is a really important stabilizer of the spine, especially in the low back. Make sure that those vertebrae stay really closely in alignment with each other. Then we got the posterior longitudinal ligament, which runs on the posterior aspect of the bodies. It's not quite as strong, and it doesn't have as strong of attachments to the intervertebral discs, so it's not as important of a stabilizer as the anterior longitudinal ligament. And then the last one is, it basically runs along the laminas, and so that's the ligamentum flavum. And you can see it labeled over here. It means yellow ligament, and it's named that, or it has that appearance of being kind of yellow because it has a lot more elastic fibers. So remember, elastic fibers are a kind of a specialized type of collagen fibers where they have a little bit more give to them, but they also then rebound to their original shape more strongly, as opposed to your more typical collagen fibers kind of limit end range of motion, but they're not as much like rubber bands. They don't bounce back to their original shape quite as vigorously as the elastic ligaments do, or the elastic fibers do. So the ligamentum flavum is yellow because it has a high content of elastic fibers. So it's also a pretty strong stabilizer on that posterior aspect of the spine. All right, the ribs. So what you're looking at here is an anterior view of the fifth rib from the right side. So you look at the right side, right rib, fifth rib, and an anterior view. So I'm actually going to switch, now that I've told you that, now I'm going to switch views. So now you're looking at a medial view of the same rib. So you're looking at it from, basically looking out from the vertebral column. So in terms of the landmarks on ribs, the first really obvious landmark, the most medial structure, is the head. So all of this is the head of the rib. And then it has two articular facets. So there's a superior one up here and an inferior one down here. And so remember that those are going to interact with, so this is where things get a little complicated. The superior articular facet here is going to interact with the inferior costal facet of the vertebrae above it. And this inferior facet of the rib is going to interact with the superior costal facet of the vertebrae below. So that's how that works. Then we got the neck of the rib, which is through here, so that's that narrowing area. Then it's not super obvious from either this view or this view, kind of here. So there's a bump that is fairly obvious on the posterior aspect of the rib, and that's called the tubercle. And then the tubercle has an articular facet. So that's what this is indicating here, is an articular surface or hyaline cartilage right there. And so that's the articular facet on the rib. That's going to interact with that transverse costal facet on the adjacent vertebrae. Then we got the angle of the rib, which is right here. So you can see a pretty obvious angulation. And then if we go back to that anterior view, everything, so the angle's here. Everything in front of the angle is the shaft. So it's kind of like the diaphysis of a long bone. So this is all the shaft of the rib. And then the costal end is over here. That's what's going to interact with the costal cartilage that helps connect the ribs to the sternum. So that's the costal end. So the costal end is on the anterior aspect, the head is on the posterior aspect. Speaking of the sternum. So the sternum has three parts to it. And so this is kind of I've rotated the skeleton down a little bit for this view, but this is the sternum by itself, and you can see that there are some really obvious lines here that separate different parts of the sternum. So here's one line right there, and then there's the other line down there. So the most superior aspect of the sternum is called the manubrium. So the top part of the sternum is the manubrium. It has a couple of landmarks on it. It has two clavicular notches, one on the right and then one on the left. And so the right clavicular notch, and again, I know it's the left side looking at the picture, but it's in the model's right, or on the model's right. So this is the right clavicular notch there, and then there's the left clavicular notch. So thinking all the way back to the beginning of the class when we talked about the sternoclavicular or SC joints, here's your SC joint here, or your right SC joint. So the clavicle would be sitting right here, and so that would form your right SC joint there. So that's your clavicular notch on the right side, clavicular notch on the left, and then the one in the middle is your jugular notch. So that one's the jugular notch right there. Then, below this line, or inferior to this line, is the body of the sternum. So all of this is the body of the sternum. Then down here, again, you got another line. So down here, this most inferior aspect of the sternum is called the xiphoid process. And so the xiphoid process, if you in CPR class, if you've taken CPR class, but two, if in CPR class they warned you not to put your hands too low on the sternum because you could fracture part of it, what they were trying to do is to make sure that you're not compressing the xiphoid process, because theoretically then you could cause a fracture at this intersection, and so you could cause that xiphoid process to poke down and in to the thoracic cavity, and obviously that would be bad. And then the last thing is the costal cartilage. So what I'm going to show you next are highlighted sections of each. So there's the manubrium. It's highlighted in green there for you. So again, the most superior part of the sternum. Then we got the body. And then we got the xiphoid process there. So again, that most inferior aspect of the sternum. And then we'll add the costal cartilage. So what I've highlighted for you there in green is the right costal cartilage, and then the left is kind of in that light blue color there. So there's your left costal cartilage, and there's your right. All right, so there are a few muscles I want you to know from the vertebral column. You've probably noticed, if you have the lab sheet in front of you, that I don't have origin and insertion on there, and that is intentional. So for any of these muscles of the trunk, origin and insertion is on the slideshow, but you don't have to know it. So ignore origin and insertion. I want you to know the muscles, be able to identify them from a picture, and I'll use the same pictures on the quiz that you're going to see here in the slideshow. So be able to identify them from a picture and know their actions. So I'm mostly concerned that you know their actions. So just muscle and action. Don't worry about the origin insertion stuff. So the first group that I want you to know is called the erector spinae group. And the reason I want you to know them is they are the primary, or as a group, they are the primary extensors of the spine. And so the erector spinae group has what are referred to as three columns. And so the three columns are the iliocostalis muscle, which is the most lateral of them, and then the longissimus column or section, which is one in the middle, and then the spinalis, which is the most medial of the three. So from lateral to medial, they run iliocostalis, longissimus, and spinalis. And so what you've got highlighted for you here is the iliocostalis in the lumbar section. So this is iliocostalis lumborum. There are actually 3 total iliocostalis muscles. You don't need to know that, but that'll help prepare you if you go into more detailed anatomy later. The other 2 iliocostalis muscles, there's one in the thoracic section, which is called iliocostalis thoracis. Iliocostalis thoracis. Yeah, thoracis. And then the last one is in the cervical section, so in the neck, and that's iliocostalis cervicis. So know that the erector spinae group is active or are agonists for extension of the spine. And if we only activate one side, so if we only contract this side, then they're involved in lateral flexion of the trunk. So if the right iliocostalis muscle contracts, that's going to cause right lateral flexion of the trunk. So there's iliocostalis. And then again, the middle one of the three is the longissimus. And so what you're looking at here is longissimus thoracis. And so like iliocostalis, it also has two other ones in different sections of the vertebral column. So not only is there longissimus thoracis, but there's also longissimus cervicis and longissimus capitis. So capitis moves the head, cervicis obviously then moves the neck. So again, same thing with longissimus. So what I want you to know, it's the middle of the three erector spinae group muscles, and it is also an extensor and then a lateral flexor to its same side. And then the last one is the spinalis muscle, and you can see it there. So just like the other ones, there are actually two sections of the spinalis muscle. So there's spinalis thoracis, which is the one that's highlighted here, and then there's spinalis cervicis, so the one in the neck. All of them are going to be, again, extensors and lateral flexors of the trunk. So the erector spinae group then, iliocostalis, longissimus, and then spinalis. And remember that all of them are extensors of the spine and lateral flexors of the spine. All right, and then, there's it by itself. Then we're going to go to the low back, and this is the deepest layer of muscle in the low back. This muscle that's highlighted for you, there's a right and a left. This is the quadratus lumborum. Again, you don't need to know origin insertion, just want you to know action. So quadratus lumborum is going to be a lateral flexor of the trunk, particularly in the low back. So what you can see there is that it bends the trunk or flexes the trunk to the same side. So if a muscle bends the trunk to its side, or the same side, that's called the ipsilateral side. So ipsilateral is same side, as opposed to contralateral is the other side. So when the right quadratus lumborum contracts, it's going to cause you to bend over toward your right, or to laterally flex toward your right. So it bends you, flexes you to the same side that the muscle's on, so flexes you to the ipsilateral side, or same side. So the reason I put quadratus lumborum on there, it's an important pelvic stabilizer during gait. So we talked about gait, we had a whole thing on it last time. But as you are in the swing phase, you're going to get the quadratus lumborum stabilizing. So if the left leg is in the swing phase, quadratus lumborum is going to be contracting, actually on both sides, to be stabilizing the pelvis to prevent pelvic drop. But then also as you move farther into the swing phase, the quadratus lumborum on the same side is going to contract a little bit more strongly to help elevate the pelvis on the swing side. And then that'll allow for more ground clearance during the swing phase. So quadratus lumborum, know that it's a lateral flexor to its same side. Then we got transversus abdominis, more commonly just called transverse abdominis. So transverse abdominis is the deepest of the three layers of abdominal muscles. And so it kind of looks like a weight belt. So it originates back on the thoracolumbar fascia, so it originates back on the low back. But you can see it also has an origin along the iliac crest and then along the inguinal ligament down here. And then it's going to insert on something called the linea alba. And the linea alba is this structure in the middle here. So it is basically a tendinous seam that runs from the sternum, specifically from the xiphoid process of the sternum, down to the pubic symphysis, which is that ring of fibrocartilage that sits between the innominate bones. So all of this then, this white line in the middle, is the linea alba. And so transverse abdominis inserts into it. What does transverse abdominis do? One of its more important things is abdominal compression. And so what does that mean? That means if you suck in, so when you draw your belly button, also known as your umbilicus, if you draw that towards your spine, that's abdominal compression. And so transverse abdominis is important in that. When you draw in, when you suck in your belly button toward your spine, one of the things you'll see there is that causes a posterior pelvic tilt. So it causes the ASIS on both sides to rotate backwards, and so then that puts the lumbar spine in a little bit of flexion, or at least in a neutral position. And so the reason I wanted to include transverse abdominis on here, actually, so basically the group of muscles that I've included are what are commonly referred to as the core muscles. Because I hear people all the time talking about like, oh, you got to work out your core. Like, okay, well, what's that mean? And they often don't know the muscles that are involved. So these are most of them. There are others, but these are most of the core muscles. And so transverse abdominis is a really important one because it plays that role in control of the pelvis. So it helps you, again, posteriorly rotate the pelvis, but it's also an important stabilizer of the low back. So transverse abdominis is a really important stabilizing muscle. It's also relevant whenever we do things like bridges, or planks, whatever you want to call them. So if you're doing like a prone, which is face toward the ground, bridge or plank, one of the things you want to do first is to draw in. So you suck in, bring your belly button toward your spine, and then you pick your hips up off the ground. And then once you can't maintain that posture, so basically when your pelvis rotates forward or rotates anteriorly, then that's the end of the exercise. Because when your pelvis rotates forward, you can still stay up, but what the muscles that are involved in keeping you off of the ground at that point are no longer primarily the abdominal muscles. You're primarily using your hip flexors. So like iliopsoas, rectus femoris are keeping you off the ground. Which if you're doing that exercise, you're probably not trying to work your hip flexors. You're probably aiming to work your abdominal musculature. So any of those exercises, whether it's a prone bridge, a side bridge, renegade rows, those kinds of things, first thing that needs to be done every time is to draw in and then do the exercise. And then once you can't maintain that pelvic position, then that exercise is over. So that's transverse abdominis that's going to be primarily responsible for that drawing in. But in addition to that, because it's an important stabilizer of the lumbar spine, it's also involved in basically every motion of the trunk. So it's involved in rotation, flexion, and lateral flexion of the trunk. Then we've got the one that everybody knows, if not by name, but it's your 6-pack or 8-pack muscle, which is your rectus abdominis. So you can see rectus abdominis sits superficial to the transverse abdominis. So it's going to run from, it actually technically originates distally or inferiorly. So it originates down here on the pelvis, inserts up here along the sternum and along the costal cartilage. And so, as you probably know, your 6-pack muscle, your rectus abdominis, is involved in trunk flexion, which you know because you have probably done some iteration of crunches or sit-ups. And so when you do that, that's trunk flexion. But it also plays a role in compression of the abdomen, so in drawing in to some extent, not as much as transverse abdominis, and then stabilization of the pelvis. And then 2 more muscles, our internal oblique, and then our external oblique. So internal obliques first. So internal oblique, one of the things I want to call your attention to with the internal oblique is the direction that the fibers run. So the fibers run this way. So they run from posterior and inferior, because you can see they originate on the thoracolumbar fascia, which is in the low back, along the iliac crest and along the inguinal ligament. So they originate all along here, and then it's going to insert along the ribs, but also into that linea alba where transverse abdominis also inserted. So the fibers run, again, from the posterior and inferior aspect to the anterior and superior aspect. Why does that matter? Because that dictates what the muscle does. So if a fiber runs from here to here, when that fiber shortens, it's going to cause lateral flexion to the same side, but it's also going to cause rotation to the same side. So if I contract my right internal oblique, that's going to rotate me to the same side, so it's going to rotate me to the right side. So again, there's that ipsilateral. So the right internal oblique rotates me to the right side or the ipsilateral side. Also plays a role in abdominal compression. So again, going to bring your belly button in a little bit, and then you can see diaphragm antagonist. Your diaphragm is your primary breathing muscle. It separates the thoracic cavity, so your chest cavity, from the abdominal cavity. And so normally when we breathe out, we just relax. So like at rest, when you breathing in is active, breathing in requires energy, but then breathing out, exhaling, doesn't require energy. Basically, we just relax the breathing in muscles, so primarily the diaphragm, and then we let gravity swing our rib cage back down and in, and so that forces the air back out. But during exercise, we have to breathe more forcefully and we have to breathe more rapidly. And so during exercise, we have to engage active expiratory muscles. And so the internal oblique is one of those. So it's going to contract to compress the diaphragm to actually push it back up into the thoracic cavity and then help us forcefully exhale. So the internal oblique is an important breathing muscle during exercise. And then the last one, oh, there's another internal oblique picture. The last one is the external oblique. So one of the things I really want you to know is that the external oblique versus the internal oblique, the fibers run different directions. So the external oblique, the fibers run from superiorly to inferiorly, so posterior-superiorly. I don't know if that's right, but anyway, from the more posterior aspect, they're superior, and then they run inferiorly and anteriorly. Okay, so the fibers run this way. And why that matters is when those fibers contract, they're going to rotate you to the opposite side. So the right external oblique rotates you to the left side, which is the contralateral side. And then the external oblique also flexes the trunk to the same side. So the right external oblique causes lateral flexion to the right. And again, trunk flexion, so assists in sit-ups or crunches. And then it's also, like internal oblique, an antagonist to the diaphragm. So it plays a role in forceful expiration or forceful breathing out during exercise. And then one other thing I wanted to point out is this aponeurosis, this sheet of connective tissue here. So you can see the rectus abdominis is not visible anymore. It's actually deep to this sheet of connective tissue. And so that's called the rectus sheath. And so what that connective tissue does is it helps keep rectus from what's called bowstringing, so kind of like popping out whenever you flex the trunk. Because without that sheet of connective tissue, without that rectus sheath, then whenever you did a crunch, your rectus abdominis would kind of pop out a little bit. And so to prevent that, we have this sheath formed by the connective tissue extending from both the internal, because here's the internal one, extending from both the internal oblique and then the external oblique as well. So that all this white stuff here is the rectus sheath that, again, keeps the rectus from bowstringing out. All right. Oh, so then one more thing just as a point of emphasis. So let's say, for example, if I rotate to my left, so if I'm, we'll just stick with that. So if I take my sternum, rotate it to the left. In terms of the oblique musculature, as I'm rotating toward my left, I'm going to use my left internal oblique, because again, the internal oblique rotates me to the same side, and then I'm going to use my right external oblique, because it's going to rotate me to the opposite side. So just be aware of that's the interaction between the two of them. And that is all I have for you on the axial skeleton. So mostly being able to name bones, relatively few landmarks, and then only a handful of muscles. And remember, you only need to be able to identify the muscles from a picture and then identify their actions. All right, so have a good break, and then we will see you again to talk about the peripheral nervous system.